Good afternoon, ladies and gentlemen, and thank you for waiting. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Mr. David Hall. Mr. Hall, the floor is yours.
Thank you, Wes, for that introduction. Again, I'm David Hall, and on behalf of VHQC, the Maryland Patient Safety Center, and the Maryland Hospital Association, I'd like to welcome you to our second event for Stopping Sepsis in Long-Term Care. As before, just a few housekeeping details before we get started. First, this webinar will be recorded, and a transcript will be available. You'll get an email when this is available on our website. Also, during the webinar, we'll have the chat function enabled. We'll be monitoring chat and we'll respond if possible during the webinar. If not, we will address those questions at the end during the question and answer session. At the end of the session, there will be our standard evaluation. We ask that you do complete that. It helps us with future event planning. And when we do that, we'll open the lines for questions and answers. So again, welcome today to our seminar. Again, I'm going to introduce myself to you. I'm David Hall. I'd again like to reintroduce our team to you again this month. From VHQC, we also have Sheila McLean, who was our program director for the state of Maryland. From the Maryland Patient Safety Center, we have Bonnie DePedro. And from the Maryland Hospital Association, we have Justin DeOmbra. And again, we're very pleased to be working with these organizations, and we're looking forward to our continued engagement with them on the Stopping Sepsis and Long-Term Care project. As with our last webinar, I encourage you to commit to being attentive and engaged, open, collaborative, and actionable. As I mentioned before, I know we all are very busy, so that you can just put your cell phone on mute and minimize your email screen and take just about the next 45 minutes to be engaged with us. I think you'll find it very helpful. Our agenda for today, again, we're going to overview the Sepsis 100 Toolkit, which will provide tools for you going forward. We're going to review the data that we'll be providing to you. We're going to review some data that we're going to ask you facilities to self-report to us. We're going to review some communication aids to help with the project, look at some next steps for advancing our QAPI projects, and then look at some what's next with the Stopping Sepsis project. Let's just do a quick review of some of the items we covered in our first kickoff webinar that will also be important for today's session. You'll probably see this slide often, probably on all of our webinars, to remind us of why we're in this project. Again, this is about saving lives and secondarily reducing hospitalizations. As we talked previously, sepsis is the leading cause of hospital admissions for nursing homes. Up to 1 million Americans are diagnosed annually with sepsis, and up to 50% of those folks will die as a result. Some more sepsis facts that you may not have seen. These findings were reported in a November 2015 brief from the Healthcare Cost and Utilization Project from the Agency for Healthcare Research and Quality and the Nationwide Readmission Database. You'll notice that in addition to being the leading cause of hospital admissions, sepsis is also the most responsible for readmission to a hospital within 30 days. It's also the most expensive diagnosis. And it also highlights the need that we need to improve communication among caregivers after an acute care discharge with sepsis. Again, just to quickly review, this is a list of the Maryland acute care hospitals that are in their Improving Sepsis Survival Collaborative. And this slide is a list of the nursing homes that are working with us in this project. As before, we encourage you to look at both groups. See what facilities are in your areas, and see the ones that you may be working on a regular basis. So as the project goes forward, you'll have an opportunity to work more closely together. Again, to review just a bit, last webinar, we visited with the ABC Nursing Care Center. They were challenged by their local acute care provider to become a part of their preferred post-discharge network. But they were asked by the hospital representative if they had any sepsis reduction efforts in place, or if they had any formal process to review hospital admissions. We introduced the PDSA model for improvement, And if you remember, the administrator decided with his management team to begin a sepsis reduction project using the PDSA model. And remember, the model for improvement asks 3 questions. What are we trying to accomplish, or what is our aim statement? How do we know that change is an improvement? And what changes can we make that will result in improvement? You remember the administrator with his team developed a plan. Again, this is the P in the PDSA process. And their plan says they were going to use the Seeing Sepsis Toolkit to start their journey to reducing sepsis in their facility. We showed an example of one of the tools developed by the Minnesota Hospital Association. And they are based on the simple principle of Seeing Sepsis 100. Warning signs of increased pulse, decreased blood pressure, and increased temperature, and a change in the usual condition are signs of sepsis and should initiate additional assessments from licensed staff. Today, we will introduce you to all the tools available from the Minnesota Project. These tools, as well as the communication aid that we will discuss, become the D in the PDSA cycle. These are things that you will do to help you meet your goals. As we introduce the tools, you will move on to S for the study part of the PDSA. You will have to collect some data, study the effects that your tools have on your sepsis reduction efforts. And again, we remind you that all these tools will be posted to our online community. Our plan stated we would attain and train our staff with the Seeing Sepsis tools. This is the first tool with the Seeing Sepsis 100 pocket card. Again, the warning signs of pulse greater than 100, blood pressure less than 100, and temperature greater than 100, and a change in condition are signs of sepsis, and serve as a reminder to further assess the resident. We hope to be sending each facility a supply of these cards to distribute to your staff. Again, they are also available on our website for you to access and use. This is an example of just one card. I know as I travel about hospitals and nursing homes, we see many such cards where they are attached to our name tags and badges to make them really accessible to our staff and serve as a reminder. And again, we hope to be sending each of you a supply of these, but you can also go on our website and make your own. The next tool is the Early Detection Flyer that reviews Act Fast, Early Detection of Sepsis Requires Fast Action. This is a flyer that can be posted in med rooms, break rooms, on med carts, and other prominent locations. It emphasizes that we must act fast when sepsis is suspected. You will note that every hour a resident in septic shock doesn't receive antibiotics, the risk of death increases almost 8%. This highlights the fact that we have to know our residents well. We need to know the status of their advanced directives. Does the resident or their family want urgent emergency care for these situations, or they want to stay in the nursing home and be treated there? Knowing the wishes saves valuable time. Having to backtrack and locate and talk with family members can lead to a loss of treatment time and delays. And again, we hope to send a supply of these to each facilities. And again, I'll remind you each time that they are also posted on our online community where you can print your own copy. The next tool is a flyer that guides us in the care of the resident. In addition to highlighting the 100 screen, it probes the possible causes of infection. UTI, respiratory, skin infection from pressure ulcers, etc. It again highlights the need to know the resident's wishes quickly through advanced directives review. And it guides you with steps to take depending on whether the resident desires treatment and in what setting they want that treatment. We recognize that there is great variation among the level of care that homes provide. Many of you can start IVs, initiate IV antibiotics, and obtain lab work. You will have to base your actions to reflect the amount of care you can deliver. In many cases, the quick transfer to acute care will be indicated quickly. And this tool is a little hard to read on the slide. That's here just for references only. Again, it's on our online community for you to download. It provides a guide to protocols to get the needed care to residents who might be septic. Another tool for your use is this algorithm. It provides a decision tree to assist in determining if sepsis is present, provides a quick reference for treatment, and the setting of treatment. If the 100-100-100 tool triggers, this will guide the next steps. You'll note on this slide that the word SBARS is mentioned. Way back in 1992, the American College of Chest Physicians introduced definitions for systemic inflammatory response syndrome, or SBARS, which is involved with sepsis, septic shock, and severe sepsis. The idea behind defining SBARS was to define a clinical response to an insult of either infectious or non-infectious nature. SBARS, that you'll note, is defined as two or more of the noble variables, and it is a great complement to the 100-100-100 pocket cards. Again, it relates to fever, heart rate, respiratory rate. And it's worth noting that SBARS is nonspecific and can be caused by ischemia, inflammation, trauma, infection, or all those combined. SBARS is not always related to infection. It can be those other items too. This tool is a poster that has a collage of all the seeing sepsis learner tools. It shows all the tools that are combined on one nice poster, and again, it can be posted in prominent locations to highlight the warning signs of sepsis and treatment. And we hope to send each facility a few of these to be posted, and again, they will be available on our website. The Seeing Sepsis Road Care Map. This is an audit tool that reviews the facility's core strategies for the early detection and treatment of sepsis. While your facility may not have the capability or resources to implement some of the noted medical protocols, the questions can easily be adapted to your long-term care setting. It provides a quick process to identify if the needed protocols are in place and prompts you to embed sepsis into your performance improvement program with regular data sharing and updates to your staff and other stakeholders. Remember this slide? This highlights that this is an ongoing process that requires effort and teamwork. You must set goals, use data to track performance, use teams to pilot test new ideas, and empower your staff to solve problems. And through much effort and teamwork, we can equal success. All the tools that we have just reviewed will provide you with a framework to introduce stopping sepsis in your long-term care facility to your staff. You can demonstrate to them why this project is important and its implications to all Maryland healthcare facilities. The Seeing Sepsis 100 tools provide you with the resources to educate your staff and to begin efforts to recognize and start treatment for sepsis earlier, and more importantly, as we move forward, will help you to reduce the conditions that lead to sepsis. Last webinar, we reviewed the data that VHQC will provide to you. And again, I want to emphasize that your data will not be shared with any other entities, regulatory or otherwise. The only instance will be with your permission, and we usually limit when somebody has a great success story, we may ask that you share your story and your data. That again would be your decision. Over the next several slides, I will review a sample of each report and how it will be presented to you. Again, the data we'll be giving you will be percentage of sepsis admissions to the hospital, percentage of sepsis ED visits, percentage of sepsis observation stays, percentage of sepsis admissions that were readmitted, and percentage of sepsis admissions that resulted in death. Your initial report package will be from calendar year 2014, which will provide us with a base rate. The first report will look like the graph on your screen and will display the percentage of sepsis admissions to hospitals from nursing homes. You will note that it provides the numerator and denominator and their definitions per quarter and the calendar year 2014 total score. It gives the raw number plus the percentage, and also provides the overall state rate and the rate of long-term facilities that are in this project. You'll note this report highlights a total of 50 admissions with 10 being sepsis for a calendar year total of 20%. The graph provides a good visual tool to highlight performance. Note that in quarter 2, it had the highest rate with 5 of 11 or a 45% rate. When you see spikes like this, it provides an opportunity to look back and review if there were special causes that may have caused this variation. Items such as staff turnover with an accompanying influx of new residents or a spike in flu cases may have contributed to a spike when you see it like this. The next data point you will get will be emergency department visit rates. You might note that the numbers on this slide are different from the last, so this shows ED visits only. Sometimes there is confusing. When someone goes to the ER and is admitted, that becomes an admission rate. When they go to the ER and are discharged from the ER, that's the ER visit. So sometimes folks think the numbers don't add up. Again, ED visits reflect only those who visited and were discharged. This slide demonstrates the same data for observation stays. It may be helpful in showing the observation numbers for any cause. However, since by definition sepsis is a medical emergency, we may not expect to see a resident with sepsis placed in observation. If we do, again, it may be worth going back and reviewing the case to see if there were communication issues such as advance directives where the patient was in the ER and then the family or resident says that they don't want to be treated in an acute care setting and they may be placed in observation pending transfer back to the facility. This slide has the 30-day readmission rate. It draws attention to the earlier discussion, noting that sepsis is also the leading cause of readmissions. Again, when a resident is admitted to a long-term care facility after an acute inpatient stay with a discharge diagnosis of sepsis, it may highlight the need for closer monitoring after the long-term care admission. You'll note that both the state and the nursing homes in this project, almost 30% of the patients were readmitted within 30 days. So with almost 1 in 3 getting readmitted, this will be a good opportunity to develop protocols to more closely monitor these residents on admission. As we continue down this road together and we move through more PDSA cycles, this could be another tool you develop to assist in reducing your sepsis efforts. As when somebody is admitted, you may want to monitor more closely to prevent the readmission. And the last tool, or the last data set we'll look at, has the mortality rate. When we reviewed the literature, and as we also noted on the earlier slide, we see that the sepsis rate for the death rate for sepsis is in the 25 to 50% range. So the state average and nursing homes in this project are slightly below this. This is a good trend, and hopefully will continue to show an improvement as we roll out this project to your facility. This slide demonstrates the data that VHQC will be requesting from the facilities participating in the project. Hopefully, as you read down the list, there will be data that you already have or can be collected easily by pulling from your existing data. We know how busy everyone is, and we tried to make this least labor-intensive that we could. You will note that we're asking for raw numbers only. We hope that you can start collecting this in March and begin submitting this to us in April. You'll be getting an email explaining in more detail how to submit. Our goal is to have a web portal where you can log in and submit your data. If for some reason we don't get our portal developed in time, we plan to use a tool such as SurveyMonkey, which is based on the same concept. You will get an email with the link to log in and submit using the survey tool. After a few months, our analytical staff will begin to put this information into graphical format for your review. Since CMS data is usually 6 months behind the calendar year, we can also look at comparison data between what is being reported and what is the official CMS coded data as we move forward in the coming months. We've now reviewed the data portion. As we get further into the project, we may find that some of the data is more beneficial than others, and we can adjust it as needed. However, we'll always emphasize admissions, readmissions, and mortality data. Again, remember our teamwork slide. Communication is critical to the effectiveness of a team and ensuring patient and resident safety. Over the next several slides, I'll be introducing and discussing a method that's become widely adopted and accepted among healthcare providers. It's called SBAR, and it's endorsed by the accrediting body for hospitals, the Joint Commission. It's recognized by the Agency for Healthcare Research and Quality and the Institute for Healthcare Improvement, as well as many other patient advocacy groups. Since our goal of this project is to recognize and prevent sepsis and other infections, we're going to review this tool that has been used greatly to improve communication among healthcare providers, especially when used to report on a change in a resident's condition. Again, you'll notice SBAR Communications. SBAR stands for Situation, Background, Assessment, and in a long-term care setting, it stands for Review and Notify. In the acute setting, R is often for recommendations. Again, there are many communication tools and techniques that can be used to ensure effective communications, but SBAR provides a standardized framework for members of the healthcare team to communicate about patient's condition. SBAR is an easy-to-remember, concrete mechanism that is used for framing any conversation, often a critical one requiring clinicians' immediate attention and response. SBAR originated with the U.S. Navy submarine community to provide critical information to the captain. If you've ever been watching TV and you may have seen a commercial for a Navy commercial for submarines or looked in magazines or other media, you may usually notice that the submarine crew consists of a very young group of folks, usually 18 to 22 in age. This tool was used so those folks could quickly communicate things to the captain that was of serious nature. Again, to review the bullets, it's a format for nurses and other providers to share relevant information. It's been shown to be especially effective in sharing information with physicians. The primary objective of SBAR is to provide accurate information about a resident's care, treatment, current condition, and any recent changes. And again, attributes of effective communication includes allowing opportunity for questions between the giver and the receiver. And in standardizing the communication between nurses and physicians ensures accuracy in the information to meet the resident's care and safety goals. And it provides a consistent way of providing information. And again, this format is being used by other disciplines across the country. This is an example of an SBAR that has an acute care focus, but it can easily be modified to meet your individual facility's needs. As we move down the form, you can see that it provides a concise roadmap to state who you are, the resident, and the problem. It provides a good background in the assessment section that you expand on your reason for calling. This is a good point to stop and talk about the R section for a few minutes. I know that in many long-term care facilities, the LPNs often fulfill the role of charge nurse, and there's limited RN support, especially during off hours. State nursing practice acts usually have language that supports only an RN can do an assessment. So in the long-term care setting, the SBAR has been modified to have the R again stand for review and notify. This allows an LPN who is contacting a physician to review vital signs and highlight other pertinent observations such as decreased output or increased wing drainage, and avoid any conflicts with practicing outside the scope of their licensure. We will review an example developed specifically for long-term care use in just a moment. And as we've talked about before, this one again emphasizes that family input regarding treatment options prior to calling, so you would know if they want to be treated in an acute setting or stay in a facility. Again, SBAR provides a vehicle for individuals to speak up and express a concern in a very concise manner. This is an example from one of the hospitals participating in the acute care and treating sepsis survival campaign. One of the goals of this project is to get the long-term care facilities and these hospitals into a closer relationship. As we see from this example, this is a SBAR devoted strictly to sepsis. And I hope as you look at this, you can see some opportunities for dialogue with the facility that you work the most with and possibly see a development of an inter-facility SBAR that would let you contact the acute care facility and let them know that you're sending a suspected sepsis patient. And it would prompt them in turn to be prepared to put their sepsis protocol in place and be prepared when the resident arrives. This slide directs you to a web address for Interact. Interact stands for Interventions to Reduce Acute Care Transfers. This is a quality improvement program that focuses on the management of acute change in resident conditions. It includes clinical and educational tools and strategies for use in everyday practice in long-term care facilities. The current versions of the Interact program were developed by the Georgia Medical Care Foundation under contract with CMS, and the latest versions were developed by an interdisciplinary team at Florida Atlantic University. When you go to Interact and you click on the tool section, you will find an SBAR form developed specifically for long-term care. It is more detailed than many other examples that we've shown. It consists of 4 pages. This is a screenshot of the first 2 pages, and although it's difficult to read, we wanted you to have opportunity to see what it looks like. This link will also be posted on our online community to get you to the Interact site and these tools. And the Interact site has many tools that assist in improving resident care. Again, this slide is the first 2 pages, and this slide highlights pages 3 and 4. And again, as with others, this is shown to demonstrate a variety of forms. If you choose to use SBAR, you can choose one that we've highlighted, and you can start to use it, or you can easily modify any of them to meet the needs of your facility. The goal of introducing the sepsis tool and reviewing SBAR is again to provide you a framework to move forward with the Reducing Sepsis project. Using the Sepsis 100 tools provides a method to more rapidly identify suspected sepsis, and the SBAR gives you a method to communicate your concerns. The SBAR can be used internally by direct care staff to get the attention of licensed staff for further assessment, and they can in turn be used by those licensed staff to communicate with physicians and the hospital when sepsis is suspected. So again, what are the next steps? Can we ask you to sign up for online community if you have not done so already? Again, all the tools that we've talked about and links to these other resources are on that site. We ask that you participate in our upcoming events that will be on our online community and sent to you by email. And again, these slides and resources and recordings will be posted at the online community. Again, we provided you a screenshot of that community. You'll see that we have a dedicated page for stopping sepsis in long-term care. And you click on that, then you'll get to all the resources that we've discussed. And you can stay connected with us through a variety of means, through Twitter and again online. And at this time, that was a pretty quick overview of that. We have reached the end of the formal discussion. If you post the evaluation, we'll do that quickly and we'll open the lines for questions.
Certainly the floor is now open to your questions. If you have a question or comment, please press 7 on your telephone keypad.
We do have a chat question, and Sheila will read it, and we'll respond to that.
The question is, the data we will be collecting is for a month, correct? And is it being collected for previous months? For example, review February and March.
What we're hoping to do, again, we're asking you to do your first submission in April, so we're actually going to start collecting the data for the month of March. So somewhere between the 5th and 10th of April, whatever is convenient, when you close out your month, we'll be asking you to submit the March data. So, and then it will be the same. We'll ask you to submit April's data in March, but the data we ask for first will be March data.
We have another question in chat. How can we get the education tool?
Okay, if you go to our online community, all the tools are there. Again, we're going to be sending you a small supply of each of the tools for your facility. So if you go to our online community, and you should have some instructions on how to do that. If not, email me and we'll get those to you. But all the forms, again, links to other internet sites are all on our online community.
Okay, at this time there are no questions, but as a reminder for a question or comment, please press 7 on your telephone keypad. Okay, at this time there are no questions over the telephone.
Okay, if you'll just stand by just for a few minutes after the close of the webinar, you'll begin your evaluation, and we hope that you do complete that. Again, I'd like to thank you for your time. This concludes our official program today. You'll be getting more information regarding the next event. We hope to do these the third Thursday of every month from 2 to 3, but our support organization is undergoing a major computer upgrade the third week of March, so we'll probably go to the fourth week. Again, we'll be getting information out to you soon, and also be looking for an email communication with instructions for your data input. And as always, please contact us if you have questions. Again, have a good rest of the day and a good rest of your week.
This is Sheila. David, I'm sorry to interrupt you, but we've actually had a couple more chat questions come in.
Great.
And I'm going to actually read these because we may have to open a line for dialogue for the first one because I'm not sure if I understand, but we'll give it a try. The question is, we have an outpatient dialysis attached to our facility where our residents also go. Will it be okay to just add data that we get from our end?
I'm not sure I understand that question. If you'd like to get online and explain further or type another question, we'll try to address that.
We'll give, it looks like Patricia a chance to either clarify in chat or access us by the telephone line. We'll give her a moment, and then we'll move to the next question. For the total number of infections, do you want the nosocomial one, correct?
Yes. Only, with somebody that was an infection, that's known. But we want only those facility-acquired infections, so yes.
This is a question from Patricia. Patricia, the floor is yours.
Hi, good afternoon, everyone. So I'm having difficulty in how I'm going to present the data because, like I said, we have an outpatient dialysis attached to our facility. So most of our sepsis actually comes from sepsis through, from them having line access, which is being used through their dialysis. So, like right now, I'm having difficulty figuring out whether these sepsis started in our facility or was acquired through the dialysis. So I guess my question would be like, how am I going to go about in submitting that data?
How are you currently tracking that data when you do your infection control report? Are you taking credit for the ones that occur in that facility, or do you have a separate report giving them the credit for those infections?
No, I only collect data from when we establish sepsis through our own lab.
Okay, so that would be how we'd ask for that. Just the data that you're currently doing like that. That's the numbers we would want.
Okay, because I'm afraid that it will skew the number somehow. It would not be a very accurate presentation.
Just the ones that you take personal credit for, like you're doing now, is what we would like.
Okay. All right. Thank you so much.
Thank you. Good question. Again, having no more questions, I will conclude today. But again, feel free to email me if you have other questions. Again, contact with us, and we'll be getting in touch with you for the next program in March. Again, thank you for your time and your consideration, and looking forward to working with you as we move forward. Thank you. Have a nice day.
Thank you. This concludes today's teleconference. We appreciate your participation. You may now disconnect your line at this time.